The aim of this study was to establish clinically useful reference ranges for maternal serum bile acid concentrations to help clinicians managing women with intrahepatic cholestasis of pregnancy. We know that maternal serum bile acid concentrations are important because it has been previously demonstrated that when the peak concentration in a mother's blood in pregnancy rises above 40 micromoles per litre, there is an increased risk of spontaneous preterm birth, and when they rise to above 100 micromoles per litre, there is an increased risk of stillbirth. However, there is currently not a commonly used reference range, and a number of values are used in different clinical centres. There is also no consensus on whether women should have serum bile acid concentrations measured fasting or after meals.
We first recruited women with uncomplicated pregnancies and those diagnosed with ICP by their respective hospitals to take part in our standardised diet study. We took fasting and serial postprandial measurements after intake of a meal with known calorie and fat content. Women with ICP were divided into mild ICP, where all serum bile acids were under 40 micromoles per litre on the day, and severe ICP, where one or more serum bile acid measurements were above 40 micromoles. The majority of women with severe ICP had fasting serum bile acids below 40 micromoles per litre, and thus the severity of the disease would not have been identified if only fasting samples were considered. There was also a significant overlap at all times between bile acid levels of mild ICP and uncomplicated pregnancy measurements, and thus there was no good time point for sensitivity and specificity for ICP diagnosis. Given that non-fasting serum bile acids were more likely to correctly stratify the severity of ICP, we next assessed the non-fasting serum bile acid reference range in 561 women, and we found that the highest upper limit of the normal reference range was in Black women at 19 micromoles per litre.
If we use the calculated upper reference limit for bile acids in non-fasting samples in uncomplicated pregnancies, 19 micromoles per litre, as the diagnostic threshold for ICP, what would be the impact on women previously diagnosed with ICP but whose non-fasting bile acids never exceeded this concentration? To answer this question, we used results from an individual patient data meta-analysis previously performed. We compared the perinatal outcomes of women whose bile acids were always below 19 micromoles per litre with those of matched cohorts or at population level. These women have no higher risk of stillbirth than the background population, and we found a lower risk of spontaneous preterm birth. However, they did have a higher risk of overall preterm birth, likely contributed to by iatrogenic preterm delivery.
Every day of the week, we're contacted by women who are anxious and confused about whether they have the condition intrahepatic cholestasis of pregnancy. They've Googled, they know it carries with it a risk of stillbirth, so they want to ensure that they get the right diagnosis. Some of them are being told it's ICP because their levels are 10 micromole per litre or more. Some of them are being told that their bile acids need to be over 14 to diagnose ICP. And a lot of them are being told they need to fast for the test. We believe that this research will help to address these issues. We believe it will help to establish a new threshold at which ICP can be diagnosed. And this in turn is going to save a lot of women needless worry